Historically, spinal muscular atrophy was categorized into three main phenotypes: type 1, type 2, and type 3. While we are moving away from utilizing these phenotypes in an era of treatment, they may be relevant for us to review as we refer to them with regard to clinical trial data. Nancy, could you please briefly describe these three main categories and what they might mean?
Certainly. It's very important, as you mentioned, that we recognize that these phenotypes or these categories were developed before the gene was identified and before people were even very certain that this was a spectrum of one disorder. Now that we realize that the same gene is involved in all of the forms of 5q minus SMA, we are less dependent on the individual types, type 1, 2, and 3. And this is important not only because now these are going to be changing as we begin to treat the children, but also because there truly is a spectrum of disorder, from the very rare neonatal onset that most of us have only seen once or twice in our entire careers, where there's only one backup copy of the SMN2 that we'll talk about in a moment, to all the way into a spectrum where there's a type with adult onset. And it isn't really clearly delineated between these groups. And this relates, again, even to the presentation to primary care physicians and neurologists. There is a spectrum of severity, with the most frequent presentation being one during infancy, where during the first 6 months of life, but not during the newborn period, there's an onset of these symptoms. And this is what has been called Verden-Hoffman or type 1. Again, as John so eloquently put, the infants start just with making little motor progress, so that the incomplete head control that is normal in a newborn period persists and begins to look like a head lag or head instability in slightly older infants. It's very, very common for these children to use a lot of common sense and slow down their feeding when they begin to have bulbar weakness and problems swallowing, so that the way it presents to parents and to pediatricians frequently is with very slow feeding, children who seem to never feed or finish one feeding before it's time for the next. And sometimes this even presents with slow weight gain because they just can't get in enough calories. At around the time these symptoms develop, one of the phenotypic things that can be seen during infancy to separate it from other disorders is the presence of tongue fasciculations. And once you've seen these, it's very easy to recognize them again. But the important thing to remember is that these are involuntary tremulous or twitch-like movements within the muscle of the tongue. So it's not a repetitive sucking or a tongue thrusting like you can see in infants, but more of a, if the tongue is still and the outline of the tongue is stable, you'd see a little dimpling within the tongue, and that would be tongue fasciculations, something that, along with the very difficult to elicit, if not absent, muscle stretch reflexes, are relatively characteristic and should make one think of infantile onset or type 1 spinal muscular atrophy. All the other types of spinal muscular atrophy in childhood are really just smaller degrees of some of the same symptoms. So what had been called type 2, or some people characterized by spinal muscular atrophy, where the children can attain the ability to sit independently but not to progress to weight bearing or standing, is a slightly milder form. These children, in addition to having, again, marked decrease, if not absence, of muscle stretch reflexes, have a tremulousness, a tremor that appears during reach and activities, particularly in the upper extremity. This can, for some children, be so dramatic that it can be one of the first things that therapists or parents or pediatricians might notice, a very high frequency, low amplitude, even tremor. that is characteristic of the milder form or intermediate form of spinal muscular atrophy. The final form, this type 3 that people talk about, is very similar in presentation to a limb-girdle muscular dystrophy, with proximal weakness more prominent in the lower extremities than the upper extremities, and usually presents either with falls or with a change in gait or difficulty getting up from the ground or the floor. I had one patient have difficulty getting out of his crouch as a baseball catcher at his presentation with type 3 spinal muscular atrophy. These children occasionally also have some of that same tremor, though it's not always as marked as in the more severe younger children. Again, we are in an era where spinal muscular atrophy is treatable, and therefore we're working very hard, and you'll hear in a moment about newborn screening. So when primary care physicians and clinicians encounter many of the children in the future, we will be seeing them as a result of a newborn screen, where the concept of type 1, 2, and 3 is less important to the children who would all benefit from treatment and treatment early on in the course, but still gets brought up by the insurance companies who want to know what type. But that's what they're referring to as the historical type 1, 2, and 3 of spinal muscular atrophy.
Thank you for sharing that categorization with us, especially as it's one that we really refer to more in the historical sense now to provide some reference and some landscape for us.